Hello, thank you for joining us out there. I'm Mike Adcox, former president of the ACMS, and I've got the privilege of moderating a panel with our Physicians of the Year, Justin Glass and Dr. Christina Hahn. It was sure good looking at those pictures last year where we didn't have any masks on. We were all met together. Maybe those will be archived sometime. It was Isaac Newton, I think, that said, if I seem to see farther than others, it's because I stand on the shoulders of giants. And it's always been one of my favorite sayings. And all of us in training have had people that have influenced us. Anytime you get an accolade like this, you think back, and there are people that influenced your career, people in your personal life. Christine, could you tell us about one of your heroes and that helped you arrive here today?
Yeah, I'm tempted to mention Dr. Fauci, but I only met him once, but I was incredibly impressed by him. I'm sure he would never remember me, but I was in training at Duke. But I had 3 professors at Duke that really, they all pointed me towards public health and the Epidemic Intelligence Service with CDC, which is how I got into public health. I was an infectious disease fellow, heading down the clinical path and trying to find my way a little bit. And they suggested I try EIS, and I think they knew I'd be hooked, and here I am in public health so many years later. So those doctors, Dr. Sexton, Dr. Bart Reller, and Dr. David Andrews, they all were incredible mentors to me at Duke.
And then how about yourself, Justin?
Yeah, I'd probably call out a really influential faculty member who interacted with me in my first year of medical school. I went to a problem-based medical school down at the University of New Mexico. We got out into small communities for about 5 months of the first year, really different curriculum than many medical schools. And I got paired with a doc, Sam Dye, an internist down in Silver City, New Mexico, who took me under his wings and basically showed me medicine and gave me permission to grow. Expected a lot of me, expected me to show up ahead of him and be prepared to talk when I really knew very little. And I learned how complex medicine was and how much work it was going to take. And also I saw the relationships he developed with his patients and that kind of small town feel he had, and wanted that for myself.
Yeah, I remember when I was a young medical student at that point, and I met a lady named Barbara, and Barbara was bald and she had a perm cap and she had a T-cell lymphoma. And I was struck, by 2 things with that experience. I was the most junior member, and yet on rounds they said, well, she didn't have any nausea, but because you got there at 5:30 and you only had 3 patients, you could spend an hour with her, And I'd say, no, she did have nausea. And they'd say, oh, well, And so I realized even the youngest person on the medical team could still contribute. It sounds like both of you had that, And the second thing was she later that year died at the age of 32. And I thought to myself, well, the rest is gravy. At the time, we were 24, 25, So it's interesting, these people in these lovely medical careers help both patients and our mentors, what they mean to us. I'm sure all your mentors would be very proud of you from today's award. Justin, you have an amazing story where you went back to the East Coast, volunteered in the thick of the epidemic. If you had money in New York City, you were trying to leave, probably. Maybe get onto the Caribbean or get into Connecticut. Tell us a little about your experience there, if you would.
Yeah, I went out to New Jersey in mid-April, and I think that we'd done a lot of work at the residency here in Boise to get ready for COVID and recognize that COVID was going to be a little ways away, that our social distancing and kind of our state, it just wasn't happening immediately, and had amazing talent around me and support around me. And I've always come from kind of a bend of service as being why I'm doing medicine. My mom's a physician. She was a public health physician and was a really big mentor to me too. And I think I recognized that there was something going on out on the East Coast that was calling on us for a national response. And I didn't know details. I didn't know if that was really true, but it became a compelling need for me to check that out and see if it was, if there were opportunities there that I could jump into, since I had so much here. And through a series of steps that was actually amazingly fast, including a 28-minute process of getting a New Jersey license. When we talk about our country not responding to things very well, there were some things that were done in New York and New Jersey, and March, April timeframe that just made me realize how many people were working together. And that process led me to ending up in a hospital that I think was really needed for me to learn COVID, to be able to serve. And I think there was a dual purpose because I think they desperately needed another physician. And I basically worked nights for them for 1 month, doing critical care, doing cross coverage, doing ER admissions, doing what a hospitalist would do in a smaller hospital, and walked away with a lot.
What was a day in the life?
Day in life
For you?
for me there. I worked the 7 to 7 shift, so I'd show up at 7 p.m. and work till 7 a.m. There were 2 of us on at night. There had always been 1 doctor on at this hospital, but basically the hospital, this was a moment where in Boise, the hospitals had very low censuses. We had stopped elective surgeries. We were preparing for a COVID surge. They were in the middle of it. About 65% of their patients were COVID patients. They were critically ill. Probably the thing to know about this hospital is that it did all the admissions for the prison system in New York or in New Jersey. And so any sick prisoner was flowing into this hospital for their care. And then the city I was in, Trenton, the capital city of New Jersey, is a pretty underserved, pretty challenging place to live. And there's just a lot of poverty in that community. And so very sick, older patients were filling the floors. They had opened 2 additional floors. They had opened a CCU that had been closed for 2 years. It was physically very different in space from the ICU. And my job was to do ER admissions, do cross cover of several of the floors, to manage the CCU while the other hospitals managed the ICU. So my care was everything from admissions of folks who were just developing COVID to COVID patients that were 10, 20, 30 days into the process on ventilators or very ill. And then in those situations, it gets tricky too, because there's other disease processes going on that you have to still be doing your usual medical work to say, do I have the right differential? Do I have the right workup? Do we have this go in the right direction?
Tom and I work closely together. We've had several COVID patients and lost several as well. Could you comment on this notion we're seeing where patients are dying alone?
Yeah, at that point, the hospital I was in New Jersey had a very strict no visitor policy. So we were using FaceTime, phones, kind of technology to try to bring families in. On top of that was many of the patients I was working with were prisoners with pretty strict policies around whether families could be involved. I was extremely impressed with the New Jersey Department of Corrections about making exceptions and allowing families to be able to know their loved one was in the hospital, to be part of that process as they were that sick. I think something I learned in those days is sick COVID patients are really sick. Any ICU doc kind of knows that about a lot of processes, but it's very hard to have end-of-life discussions once somebody gets to that degree. And so there were more codes in those days. There were more very tricky situations than I think sometimes we're seeing now, where we're able to have end-of-life discussions that start much earlier in the process with some of the sicker patients. But it felt lonely there for supporting some of those patients, and I'm really appreciative of some of the work that's gone on around that with the hospitals these days.
Yeah, that's a fascinating story. And Christine, on the national front, has Idaho got a voice? And could you teach us, as an epidemiologist for the state, how do you interact with the other 49, and what does that look like?
Yeah, so we definitely have a voice. I've always regularly interacted with other states. Every state has public health infrastructure, of course, and we have associations. And I served for many years on the board of our Council of State and Territorial Epidemiologists. So it's all us state epidemiology types talking together. And now we're on the phone together. Every Monday we have a call, and then Tuesdays and Thursdays we have a call, which includes CDC as well. In addition, you're probably aware that the White House is having calls with our governor and our director of health and welfare. These governors' calls are, they're often Dr. Birx, Dr. Fauci are on, trying to talk to the governors about how to approach the situation. What I'd say, where I feel like I have a voice is, even though we're a small state, we got hit a little bit later, so we weren't the leaders and the teachers as much as New York and New Jersey were. There's still some things that we really do well here, and other states have asked for copies of some of our guidances that have gone out to the schools, some of our other things that we've been able to put together pretty quickly because we're a small group of people that are working together for so many years. We've been working with the schools, we've been working with the Hospital Association, the Medical Association, and so we've been able to really capitalize on those partnerships and get really some really good products. I say products out, sounds like a strange thing, but like guidances, information sharing. We've been assisting the Department of Corrections here. You're well aware, I'm sure they have a large outbreak going on right now. We actually have one of our epidemiologists kind of embedded there and working very hard to help them, and I'm on the phone with them weekly as well. So I think in some ways, even though we're a small state, we do have some ways in which we can show other states some good practices and try to give we all try to help each other, but this is one way we've been able to help.
Well, there's just no way that if you end up with a national prominence and go to New Jersey and get on these conferences, it's enough to have COVID impact our professional lives. But I would like to shout out to both of your spouses who are here tonight. Obviously, there's some conversations I won't ask you about before you dived into the federal scene and been the head of the state and went to New Jersey. And that would be Justin's wife, Marcy, is here. And thank you for allowing him to do what he did. And Christine's husband, Chuck Madrid, is here as well. So thank you very much. With that, we've talked about role models. I've been impressed with the youth. You working with residency, Justin. There's a term I think Cheryl Sandberg has introduced into society, lean in, and nursing applications are at an all-time high in Boise State. So it's not just physicianhood and providers, it's also our nurses that support, really on the front lines of this COVID outbreak. Tell us about what you're seeing in terms of the youth and the willingness to lean in.
Yeah, I'll go first. I think it's incredible. I mean, I love my job. I'm the program director of a 12 family medicine residency, and to watch the 12 new interns and my 3 Caldwell interns kind of jump into this, they've been waiting for it. They've been on hiatus for 3 months, appropriately so. They were kind of put on the back burner as medical students, and now they are out there giving great care. And I think our state is an amazing state for medical education across the hospitals. Christine coming over to our infectious disease clinics, our TB clinic at FMRI, everybody seems to have a bend towards how do you help educate this next generation and give them room to grow. And I also love the fact that we're back into taking the medical students from UW, from ICOM, from PNWU, and giving them, again, a space to grow. And I think we're going to see really inspired physicians coming out of this whole process, even as we all wonder, how disruptive has this been to the medical education pipeline? And are there going to be gaps or problems in it? I would say no. This group of young learners is learning lessons that has taken us years to learn. So very excited about it.
Christine?
Yeah, and I would echo Justin's comments that in public health, I've also heard applications for schools of public health are way up. I think people are realizing how important public health is and continues to be in ensuring the health of our society. So not necessarily all medical people, people that are going for a master's in public health or an advanced, a PhD in public health, in epidemiology, statistics, that kind of thing. It's been really exciting for us because we've had so many people that have been wanting to help. We've worked with the universities. Boise State is training up people to help the local health departments because they are struggling, with trying to contact everybody. And they are providing young people to come help us out. It's been really, really exciting to see the level of interest in helping in this very, very difficult time in which public health system in Idaho by no means has enough staff to take care of this. We need all the help we can get.
Yeah, it's an interesting time, and there's been some articles recently in terms of leadership in government. And the most important thing is to yoke your team together because these jobs are just too big for any one individual anymore. Along that same line, in terms of leadership, One of the most important things I think of physicianhood, we learned this in our ER trainings, and you had to do this in New Jersey, you've had to do it in front of the public, is in a turbulent environment to respond calmly with confidence, hierarchy your thinking heuristically. Tell us about where does that come from in both of you? You obviously have it, you're Physicians of the Year award. Your ability to calm the public, Christine, your ability to work under pressure in a COVID unit for 12 hours. And if you were going to teach that to a young person, do you have any words of wisdom?
You can let me start on this one, because Justin's letting me start on this one. Yeah, well, I always think of, my father was a history professor. And yeah, and I never took a class from him. I went to a different university and he taught it, but my sister did. And she said he was just calm, and yet apparently he had a good sense of humor, which at home we're like, what, Dad's funny, did not resonate with me. But he apparently was a good and calm speaker, and I sometimes wonder if I have that natural bent a little bit. But that said, I think we all learn from watching other people do what and try to become that person. And I think really throughout my career, not only, bring up Dr. Fauci again, because we've all been watching him lately, the way trying to, first of all, I think not sell your soul. I think be trusted, even though you don't always know the answer because this disease is so new. So to be able to say, we don't know that, or I don't know that, or you know what, I did say 3 months ago, we aren't recommending masks for the general public, but now we are. In our society, it's hard to change your message and have people not, there are people that will say, boy, you said one thing and now you're saying the other, but what can we believe? But to be able to continue to do that and have faith in what you're saying and believe in what you're saying, I think is so important. And trying to transmit that to the public, that not that you're exaggerating your knowledge, but that you're being as honest with them as everything you know, that you're telling them in the best way possible.
It really has been wonderful to see you put that into place for Idaho.
And I watch Christine and kind of these messages and kind of the large population. I'm consistently impressed and love that global look at our society and how we move a whole population forward. And I think that hasn't been my skill set. I think my skill set's been a little bit more doing what's right in front of me. What's the right thing to do today? How do I live this day, this moment in this life, and try to find the right thing to do and hopefully inspire some of those around me. And I think in a way that individual approach of who's the next patient or what's the right way to spend these 6 hours or 12 hours probably goes back to, honestly, my parents, my dad, who really, I think, taught me that life's not fair. You can't expect to get a lot out of life. You should give, and you should just consistently give, and that will return. And so I hope that through lots of examples across this state, we have the big picture, we have the little picture, and we have a lot of folks that can just keep moving forward, because I think there's more work to do right now than there was to do in New Jersey back on April 15th. And that's a really hard message for me to accept, having been I went through there, but there's a lot to come.
And on the basic biology piece of that, Christine, Bill Gates was recently featured in The Economist, and The Economist is a British rag, and usually they don't allow people with a voice such as an American entrepreneur. But he spoke to pandemics, and one of the things he's been forlorn about is that he didn't work harder to prevent a pandemic in the future. But he talked about the good things that would come out of that in terms of our knowledge of virology. If you had a crystal ball, what are the things that we'll learn from a viral perspective? I remember when I was training, bacteria, then fungus, then HIV. But we're just now on the brink of truly world-changing virology understanding. Could you speak to that?
Yeah, I think, hard to know, of course, everything, but I think one of the things that'll come out of this for sure that we're all seeing play out in real time is faster vaccine development. I heard quoted early on this spring that the shortest time from start to licensure of a vaccine has been 4 years. And obviously we're all hoping for a huge improvement on that for this virus. And yet we also want to know, and we have to be able to assure the public that corners weren't cut and that safety and efficacy has been rigorously studied. So it's a challenging time. But I think that more rapid vaccine development, you know, we've been hearing about this for a long time, that there are faster ways of developing vaccines, but I think this is the time where if we come out of this with a successful vaccine, it'll change that world forever. So that's one thing for sure. I think the other thing, and you know, I've been in public health since '95 is when I started my EIS fellowship with CDC. Is when we talk about a pandemic, we've been talking about a pandemic, you know, since then, ever since I got public health, they've been saying it's coming, it's only a matter of, you know, it's not if it's, you know, it's not if, it's when, you know, they've been saying it, but we always practiced towards and talked about a flu pandemic. It was always gonna be flu, right? And we practiced about how we'd get the flu vaccine out the door, and we've practiced about how to get those antivirals out the door for, you know, Tamiflu and other flu antivirals. Well, I think this has taught us that we don't know what virus it's going to be. It's not necessarily going to be a flu. And I do think we're, of course, entering a new era where, again, even back when I was in training, most viral diseases, there was no treatment. There were very few, you know, you mentioned HIV, of course. In the beginning, there was no treatment for HIV, and now, of course, there are fabulous treatments for HIV. So I think this will also advance treatment. Obviously, we have remdesivir now, which was one of those drugs that didn't seem to be effective for what it was initially developed for, but now we have a use for it. Other antivirals, I'm sure, are going to follow. So I think that's just a couple ideas, but I think there's going to be a lot of progress in the field of virology from this.
And on the notion of vaccines, could you comment how, if you were a primary care provider, could you give us any insight into how to respond when a patient is anti-vaccine? It's vaccine. I mean, we talked at dinner, there's subsets of our society who are totally against vaccines. I have a niece who has a young baby who's, you know, sending me anti-vaxxer information. I call it propaganda. How does one respond?
Yeah, it's really tough. I'll tell you from a public health perspective, we know there are some people that generally support vaccines. Obviously not blindly. We all want to know the science. We want to make sure that we believe that if we're vaccinating our child or ourselves, that the benefits outweigh the risks. But there are those of us that are generally supportive. On the opposite side of the spectrum, there are people that are firmly against vaccines. We spend most of our energy talking to, there's a group in the middle that we sometimes forget about. And those people are just not quite sure, right? It's a little too many shots for this baby, or do we really need all of the, you know, they're just hesitant. We call vaccine hesitant. And actually, I think that's where we spend most of our time trying to say, hey, we understand, you know, which ones are you worried about? Let's talk about that one, or let's talk about that disease, or let's work that through. The people that are firmly anti-vaccine, I think that other than patience and willingness to engage over time with that person, I think it's very hard to sit down in a single meeting and just change their mind. I don't think that we go. Justin might be able to speak to this better with how he might manage this with his patients. But certainly what we talk about in public health is that really we're gonna do a lot more moving the needle if we just educate and work with folks that just aren't quite sure and need a little more information.
Justin?
Yeah, I agree with that. I think on that one-on-one with a family that's sitting in front of you as a primary care physician, it's exploring the reasons, it's exploring what it is about the vaccine for that adult, that adolescent, that child that is worrying the parent or the patient, and trying to explore where there's cognitive dissonance, where there's some degree of conflict in the person's mind about whether this is good or bad, and can you use that balance to try to move them forward on making a decision. And there are people that have no cognitive dissonance about vaccines, and there's not a lot of work to do there other than a brief education statement. I think one of the events that's going to come out of this pandemic, though, is scientific literacy in this country is low, and the education systems are disrupted. They're disrupted majorly. I don't think I've heard the final, but many school systems this fall are going to be on virtual for the first month or for the entire fall semester. And we have to figure out a way to tap into the incredible talent of Idahoans of learning on their own, of learning in a facilitated manner online, of presenting of talking about when things don't make sense and trying to decide. And we can't give up on this subject because we're a certain way or because there's two groups with two opinions. I think we've got to dive right into it and explore that conflict and try to talk about what's the best thing for Idaho to do moving forward. And that's going to be talking to third graders, 12th graders, college students, and 45-year-olds that have been pretty fixed in their mindsets. And it's me being open as new literature comes out, as we watch what's happening with vaccines we're hopeful for, and with meds we think are working but may not be working, or meds that weren't working that now a better study says there's hope. It's all shifting very quickly.
I think that's very valuable advice. I like both of you sort of talking about, well, there's certain people you can't spend a lot of energy on because you're not going to change their mind. It reminds me of what Tom and I do in the clinic with nephron populations. We explain to patients, okay, you got a certain number that are scarred, because they ask us after they see us, why is my kidney function better than when I met you? And we like to claim it's the nephrologist effect. And so we tell them, well, there's one population of nephrons that are dead. You can't do anything about those. Another set that are healthy. But there's a group in the middle that now you're taking care of yourself and controlling your blood sugar and your blood pressure that are hyperfiltering and came back. So I guess we need to work on the middle population and middle nephrons sort of thing. How do you infuse hope in a time like this?
I'll start. I'll say that for me, like Justin just alluded to, the incredible progress that has already been made, where certainly there are people who have severe outcomes. We have people dying. I don't mean to downplay that, but we know so much more than we did in the beginning. Fewer people are needing ventilator treatment now. They have, because of remdesivir, because of steroid treatments, because of other lessons that have been learned through Justin's experience and doctors like him. The management is much better. So I think there's hope on the treatment side. I think we have hope that there's a vaccine coming. Everything we're hearing so far is promising, at least as far as those very early studies looking at immune responses. It looks promising. So I think that we have some reasons to hope.
Yeah, I'm in total agreement with that. I think death rates are down with this infection, and that's an incredibly good thing. It's not proof that this was a made-up pandemic. It's not proof that we overstated it. It's that there's been a lot of work on a lot of fronts to try to help, and yet case numbers are up. And so when case numbers are up, there's still a lot of problems facing us. And so I think the hope is to say, we have better treatments, we have better ways to keep people alive. How do we help people not get infected? How do we help spread out those infections so the medical resources are there for people who do get sick? And you know, it's not worrying about your 18-year-old, although we all need to worry. It's worrying about your 75-year-old parent or the relatively sick relative you have or good friends you have. And you have to think about the population right now in your behaviors. And I think so many of us do that. So many of us care about our neighbors here that ground swelling will help us survive this.
Well, thank you. I don't think we can entertain any questions from the audience, can we, Steve?
We could, yeah.
If anybody have any, we can do an open forum for just a bit. If anybody has any burning questions from the audience. Any comments at all from the audience here? No? Well, even though it's award night, you guys have been very generous with your time. And on behalf of the medical community, and especially the ACMS, congratulations once again.
Thank you very much.
Thank you. You got their awards.
And then we'll present your award. Thank you, Tom and Stephanie.